Hi, everyone. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation, and I'm here at the Lumbar Spine Research Society meeting. This is a meeting where doctors and scientists come together to study conditions of the low back, treatment options, and look at the evidence of the science around that. I'm delighted to have two very wonderful surgeons joining me today, and they are here to share their insight with us. I'm going to let them introduce themselves. First is Dr. Wellington Hsu, followed by Dr. Cara Sedney. Wellington?
Thank you, Rhea. Yes, my name is Wellington Hsu. I'm an orthopedic spine surgeon. I work just down the street at Northwestern University. I've been in practice for about 15 years, and my clinical focus is minimally invasive surgery of the lumbar and the cervical spine. And I also have a niche in my clinical practice for elite athletes who have spinal conditions as well.
Hey, I'm Cara Sedney. I'm the Associate Professor of Neurosurgery at West Virginia University, and I have an interest in caring for patients of rural and underserved backgrounds, patients in stigmatized groups, and advocating for them, and also in resident education, which is training new doctors.
Excellent. Well, we're going to start our program today, starting with a very common question that comes up a lot. And I'll start with you, Wellington. And the question is, what are some common causes of low back pain?
Yeah, great question. And again, it's a privilege to be here and discuss the issues with you. On a regular basis, when we see patients come into our clinic for low back pain, the far majority of my practice are folks with either an arthritis-related condition or a muscle-related condition. And those are commonly that they present in a number of different ways. Muscle injuries are typically acute accidents, either from a sport or from a motor vehicle accident. Arthritis-related conditions present generally with a more chronic and drawn-out type of history where the pain lasts for years rather than just for a couple of weeks. Treatment, which we'll get to, can be very similar for both conditions, but there is definitely the sort of stepwise protocol that each of us has as clinicians to treat these or to treat anybody who comes in, because everybody's a little bit different and their story's a little bit different. Their pain's a little different.
That's great. Dr. Hsu talked about chronic conditions and acute conditions. So acute means short-term, came on suddenly, something happened and caused the back pain. Dr. Sedney, you mentioned that you work in rural communities. Talk to us about some of the conditions you see that cause back pain in rural conditions.
Yeah, so I think the general most common things that cause back pain in rural areas are very similar to urban areas. Arthritis and musculoskeletal injuries, very, very common. Sometimes I think that some of our conditions in rural areas exacerbate those things. So different comorbidities can certainly worsen the experience of back pain that people have. In rural areas and underserved areas, the workup tends to be a little bit less intense before they get to our office. So we might see a little bit broader variety of patients that come in with back pain. They might actually have a kidney issue, or they might have a tumor or an infection, those sorts of things that are maybe not completely worked up before they get to our office, that we are doing some of that work.
And that would be because access to care is limited?
Yes.
Would that be the primary reason?
Right.
So that's so interesting. Let's zoom out for a second and let's talk about anatomy of the lumbar spine. So we're talking about the low back. Dr. Hsu, describe to us a little bit of the anatomy of the lumbar spine and why conditions happen.
Yeah, great question. So the lumbar spine involves a number of different anatomical structures, and they're all focused on providing motion or maintaining motion for activities of daily living and daily life. When one loses that motion, then folks can become stiff, they can have pain, and a number of other consequences can occur. In general, the anatomy of the spine of a motion segment consists of a disc, which is a cartilaginous or a cartilage-like structure with a soft tissue on the outside and inside that allows for motion. It also involves two bones, two square-shaped bones that we call vertebral bodies that sandwich the disc, so to speak. And then in the back of the spine, there are joints. We call these facet joints that move when patients twist, they turn, they bend, they extend. Those joints are responsible for maintaining that motion as well. Around the spine, there are also ligaments, there are tendons, there are muscles, and a host of soft tissues, as we talked about earlier, that can get injured in any way at any time and can also be the source of pain as well. And so any one of those structures that we just spoke about could, in theory, be a pain generator.
So interesting. And Cara, when we talk about the anatomy of the low back, the lumbar spine, sometimes people don't realize that the hip is involved in that. Can you describe how the spine connects to the hip?
Yeah, so the hip bone or pelvis is which is usually what people are thinking of, connects through the SI joint in the sacrum.
What does SI joint?
Sacroiliac joint.
And what does that?
It's like the sort of joints where the spine connects to the pelvis.
Right.
And yeah.
And I think sometimes people are confused that the spine is connected to the hip.
Yep. Right. And so when my patients say the word hip, they often will mean the SI joint. They point to that. Certainly that is an area of common misperception when communicating with medical professionals, because when I think of the hip as a physician, I think of the acetabulum, the area in the front and the groin area. And so, sussing that out when patients come into the clinic is really important to figure out what they mean by the word hip.
Right. So that health literacy plays a big role in figuring out a diagnosis. We talked quickly and briefly about chronic conditions and acute conditions that can cause pain or damage or injury to the lumbar spine. Let's talk a little bit about chronic conditions affecting the spine. And Dr. Hsu, can you talk to us about that? We've described the anatomy briefly. What kind of chronic things happen to that anatomy that can result in pain or loss of mobility?
Yes. So because the lumbar spine is responsible for the motion when we bend and twist our backs and our hips, over time, the motion can then lead to degeneration or a wearing out of the joints and the anatomic structures of the motion segment. So over time, as we age, and there's certainly a genetic component to this as well, the disc may start to narrow, they may start to bulge, they could herniate, and the joints of the spine can lose the cartilage over time just from the constant twisting and turning that occurs with age and occurs with activity. So generally speaking, the older we get, the more wear and tear we get on our joints of our body, and the spine is unfortunately not immune to that. So we do see these chronic degenerative or arthritis-related changes that become worse over time and with increased age. But occasionally we'll see younger individuals with arthritis-related changes as well that certainly can be subject to a genetic cause or a genetic association.
Dr. Sedney, when we think about these degenerative changes that can occur to our lumbar spine, talk to us about other factors like nutrition, status, activities like smoking, diet. How does that factor into degenerative changes of the spine, the low back?
It's a good question. It's very complex. The research is not always very clear on these associations, but we can say that certain things like weight loss can actually increase our disc height. We can say that smoking advances degenerative changes of the spine. Certain things like osteoporosis are relevant for specifically back pain and different degenerative changes. So those things can all play into the degenerative changes, although it's not completely clear how these things relate to back pain or how changing those things might change our experience of back pain.
Yeah, that's a fascinating thing. I think a lot of people don't realize that smoking can affect your disc health. And I think that's something that there has been good evidence developed to show that direct correlation. A lot of times people are confused about discs. what is a disc and what is a vertebral body. And Dr. Hsu is describing all the joints that are in the spine. You've got joints in the back of the spine, and then you've got sort of the front part of the spine, and the disc sits in between those vertebral bodies. So, Dr. Sedney, you mentioned disc height. Let's talk a little bit about the role of the discs in the lumbar spine and why they may or may not be more susceptible to degenerative changes or to injury.
Yeah, so the disc is like the sort of squishy pad that goes in between the different bones. And it's a shock absorber. It's, we move through it. It's a type of joint. And so that becomes more dehydrated as we age. You can actually see that on MRIs. The disc looks darker as the disc gets more dehydrated. And so those type of changes decrease, range of motion. They decrease the disc height, which can compress nerves and can cause pain.
Interesting. So you've talked about compressing nerves. What are the things that cause pain in the low back? And I think a lot of people will say, well, it's compression of nerves. That's an indication of a condition, right? That pain is telling you something is happening that is causing this pain to happen. So Dr. Hsu, talk to us about how nerve compression happens and what it presents. Like, what is it? How do people describe that kind of pain?
Sure. So the nerves live very close to the discs and the joints of the lumbar spine. And these nerves are responsible for function in the legs. They're responsible at times for your bowel and bladder to be controlled. And also, when affected, can lead to numbness and tingling type of complaints. So each of the nerves in the lumbar spine has a characteristic pattern that ends up in one location of the leg. So, for example, the upper lumbar spine nerves are responsible for the hip and the thigh above the knee. And the lower lumbar nerves are responsible for the foot and the ankle and everything below the knee. So that's just one example of the pattern that we look for as surgeons to determine where the symptoms are coming from. So when the joints or the discs start to wear out, they can then lead to bone formation or bulging or what have you, and they can narrow the area where the nerve lives. And so when that narrowing occurs, we call this stenosis, or a narrowing of an opening. And when that occurs, then the nerve can get irritated, and that then leads to complaints of pain, numbness and tingling, typically down the leg in a specific pattern. There are some, and we as lay people and as surgeons refer to this as sciatica, which is a general term for leg pain or radiating leg pain. At times, patients will only have buttock pain and or back pain as a result of nerve recompression and not necessarily the radiating pain down to the leg. So that's why seeing a good spine specialist is important that can interpret the clinical findings with the pathologic findings on MRI and certainly getting things to match.
Yeah, that's fascinating. I will share a personal story, and that is that I woke up one day with burning pain in my hamstring, and I was sure that I had torn my hamstring muscle. So I went to see an orthopedic doctor, and they took x-rays of my spine, and I said, no, I have a problem in my leg. And sure enough, I had a spondy at L4, L5, a spondylolisthesis with nerve compression causing this horrible pain in my leg. And I think oftentimes people don't understand the anatomy enough to know that pain or numbness, tingling in your leg can be an indication of a problem in your spine. So thank you for explaining that. I think sciatica is one of those terms that's out there a lot that people utilize a lot. Dr. Sedney, talk to me a little bit about sciatica and how you hear that term being used and how best we can explain to people what really is sciatica and how do you know if you have it?
Yeah, so, sciatica is a useful term in the sense that it really lives in the public perception of people understand what that means. It means pain that goes sort of from the back down into the leg. And so, people don't use, in general, in my experience, use the word sciatica for like just isolated knee pain or things like that. So it's there's a good public understanding of what that means. But basically, it's the medical term is radiculopathy, so it's nerve irritation. And the meaningful or good part of that from a spine surgery perspective is I like to tell my patients that surgery is like plumbing. So you have to be able to see where the problem is, where the blockage is, and open it up. And for sciatica, that's great because the actual distribution of the pain tells you where you should look, and the MRI should, in theory, show something there. So that's very helpful. If surgery is required to sort of really be able to trace it back. It's a little bit more difficult for things like back pain alone. Because of all the different things that contribute to back pain, like Dr. Hsu mentioned. And so that's, it simplifies things in some ways and makes us more successful at fixing the problem because we can actually see where the problem is, and everything kind of will tend to match up a little bit better.
So, Dr. Sedney, thank you for that description. And so now we're talking a little bit about treating conditions, right? So we've talked a little bit about anatomy. What are some of the things that can cause problems in your low back? There are long-term chronic conditions. There are short-term injuries that can happen. Let me ask the question: How would a patient know when it's time to go see a spine specialist for a low back condition? How do you know that it's time to see a doctor for that, or a specialized doctor for that?
Yeah, good question, Rita. I think in general that it depends on the where your pain is, how severe the pain is, and if there are any associated symptoms. So what do I mean by that? Most of the time, people just have back pain, and it's not just back pain, but it can be very severe. But it's usually just localized to the low back. It doesn't radiate anywhere, and it's not associated with any alarming symptoms. And so in that scenario, that's a pretty common story. So I typically tell patients that one doesn't need to see a doctor for a couple of weeks because those pains tend to go away with time, and or anti-inflammatory medications and the like. If that pain, though, is either so severe that you can't get up out of bed or is associated with radiating pain down the leg, then even then, one doesn't need to see a health provider right away, but typically a little bit of, I would say, maybe 1 or 2 weeks of pain that would then lead to a consultation with a physician of some kind. If there are associated symptoms like weakness of the leg, paralysis of the leg, bowel and bladder issues, numbness and tingling in the groin area, then those are very alarming signs that there could be something bad going on, like what we call chronic equine syndrome, which is a surgical emergency. Fortunately, that's very rare, but we do ask these questions when somebody presents with pain because it changes their course of treatment and the algorithm we use.
So my husband took out the trash. He was throwing it into the bin, threw out his back, and now he can't get off the sofa. So let that sort of rest, maybe use over-the-counter anti-inflammatory medications and see if you don't get better for a couple weeks. But if it's still going on for a couple weeks, maybe something else is happening in that situation.
Correct. And then something else could be done outside of what you've been doing already.
Great. Oftentimes we hear spine experts tell us that most of the time when patients come to see you, they don't need to have a surgery. Can you, Cara, Dr. Sedney, can you talk to us about what that's like when patients come to see a spine surgeon? Do they have an expectation that they're coming to you for surgery, or is there an expectation that there will be other treatments that will be recommended?
Yeah, I mean, I think that for my patient population, I don't necessarily think that there's an expectation of surgery. I think that they want to have someone listen to their issues and have a reasonable solution. And so for me, for many patients, that is going through the MRI with them, showing them the findings, trying to the extent that I can to explain their symptoms and which are worrisome and which are not. Reassurance is something that I offer pretty often in the clinic, and people are happy with that. And then, practical type of solutions that they can try. And, at times it is surgery, but that's, certainly not what the majority of the patients that I end up seeing actually even want. They just want to feel better, and they want to be heard.
And Dr. Hsu, do you find patients have any reluctance to see a spine surgeon for their back issues because there might be a concern that they're seeing a surgeon that might mean they need surgery? Or is there an awareness that there are other treatment options?
Most of my patients have an open mind to the treatment options that I would propose to them. And so as a surgeon, I would only offer surgery or recommend surgery to someone who has those indications. And there are certain indications that we have to go by to offer those kinds of treatments. But by and large, most of the patients that I see in my clinic don't need surgery, as you've alluded to, and are really good candidates for conservative care. And I find that patients understand that there is a role for each of these types of treatments. And they trust me, and they should trust their spine specialist to recommend the right one.
Yeah. Well, let's talk about treatment a little bit. So again, we've talked about, chronic conditions that cause issues in the lumbar spine. We talked about acute situations that can happen. Let's talk about treatment now. What is the first step when you are evaluating a patient in terms of trying to figure out what the right treatment approach is going to be? And we'll start with you, Dr. Hsu, and we'll turn it over to Dr. Sedney.
Sure. So Reed, the first step is the history and the physical examination. So a really good account of when the pain started, where the pain is, how severe does it get, is it chronic or acute, what the behavior of that pain has been over time, or associated symptoms we talked about. And then, the physical examination is very important as well. Every spine specialist will do a complete neurological examination, which will indicate the type of position or the type of health the nerves are in. And so one with a normal neurologic examination is going to be treated differently than one that presents with weakness in a certain area, and maybe even a critical area to walking, ability to ambulate. All of these things go into the physical exam as well.
Dr. Sedney.
Yeah, I mean, that was a totally complete answer, but I do think that, there end up being certain small cues in the history and physical that kind of can lead us to think of things that are maybe a little bit non-standard. So is this person, have really intense pain in the middle of their back, and is it worse when they do extension? And, could it be from the facets, or is it a woman who just gave birth and has really bad pain right up to the side of the base of her spine? Could be from SI joint pain, from laxity, from having her baby. There's so many, sort of subtleties that an experienced spine specialist can sort of sort out and sort of help figure out, because those treatment options for those people are maybe going to look a little bit different than the average.
And so after the physical exam and the history taking, you may decide to get some imaging done, right? So Dr. Hsu, when does a patient need to have X-rays or MRIs or even CAT scans?
Sure. So the folks that come into the clinic with back pain typically get an X-ray because the radiation for an X-ray isn't nearly as much as like a CT scan, and it gives us a generalized view on what the overall spine health is. I would say that we generally don't do X-rays for anybody who has pain less than 2 weeks, but over 2 weeks, we certainly would consider it. An MRI, which is what many patients come in asking for, really isn't indicated unless there is leg and back pain for over 6 weeks, or just low back pain without leg pain for over 3 months. This is the type of protocol that we utilize in order to be cost effective treating all patients with back pain. And so obviously, if there are associated symptoms that are alarming, then we have to get something earlier rather than later. If somebody's pain is more severe, that limits them to walk or what have you, then we would get advanced imaging, such as an MRI, earlier than that.
Dr. Sedney, you used the analogy to plumbing a few minutes ago. So the imaging helps you identify sort of where to go with treatment,
Right, very much. It's very important in my opinion. And in addition to the history and physical, you have to, be able to find something structurally that particularly for consideration for surgery that you can fix or change. It's also important to the limitations of imaging, though. So a lot of the musculoskeletal sort of ligament and muscular complaints are not going to show up on an MRI. And so always important to talk about that with patients, that the MRI doesn't completely correlate, like the intensity of the findings on the MRI don't correlate with necessarily their experience of the intensity of the pain. So explaining that and sort of validating that for patients, I think is really important, because patients tend to think, if there's nothing, if the surgeon sees nothing, then I'm, making this up, or they think I'm making this up, or they think there's something wrong with me. And that's not true. Like we certainly believe and validate that patient, but we want to also make sure that they can believe their own experience. Because I think there's a little bit of self-stigma that goes on for pain.
Interesting. And so when the films and the history and physical exam indicate that there might be a surgical option, how do we get there? How do we know when spine surgery is going to be a viable treatment option for somebody? And you said most of the time patients come to you and they just are given conservative approaches to treating their pain. But in some cases, surgery is the right solution. Let's have a discussion about that. When do we know that surgery is the right thing? And let's talk about some of the types of surgeries that are available and that you are specialists in doing. So Dr. Hsu, would you like to start with that?
Sure. Yeah. Generally speaking, surgery is always a last resort option, which means that most people with back and leg pain can resolve their symptoms with conservative care before surgery is considered. But after a period of time, there are some individuals who have arthritis related or other types of conditions that don't get better with conservative care, and then they become surgical candidates. From a surgeon's perspective, we're always evaluating the risk-benefit ratio when it comes to surgery and that said patient's condition. So that is going to be individualized depending on who comes in the door. Depends on their age. It depends on their medical history. Depends on their ambulatory status. It depends on their function. It depends on their goals. What are their goals of? Do they want to get back to running a marathon, or do they just want to get back to walking in the grocery store? Those are two dramatically different goals that surgery options would then be would take into account. And so, yeah, I mean, in my practice, I generally try to locate or focus the pathology to the problem in the most specific way as possible, because then that offers a more minimally invasive option to treat that person surgically. And that could either be from what we call a decompression, meaning that we clean out the area of the nerve, in a particular case, a nerve with a pinched nerve, that doesn't require any hardware or fusion. But then there are other patients who would require a fusion, which means that we put in screws and rods and cages to take the motion away from that segment in order to heal somebody's pain. And so whether you are a candidate for either depends on a number of different factors that we just discussed, and having your spine specialist look at all of those things is really important.
Yeah, I think one thing that people are somewhat confused about is, we spent some time today talking about motion and the importance of mobility in your lumbar spine, but then we talk about fusion as a treatment option when there's a problem in the lumbar spine. Dr. Sedney, talk to us about why fusions are a good treatment for some patients, and why do we sometimes take motion away?
That's an excellent question. So in some scenarios, the vast majority of scenarios that are degenerative in nature, our motion is decreased by arthritis type conditions. There are some situations where you actually have excess motion. And so that motion itself, the bones are moving, when you move in a way that they shouldn't be. And so the nerves are getting irritated in that way, where fusion is actually helpful. We are eliminating the pathologic motion. There's also a sense of sort of the glacial motion of the spine. So maybe your spine isn't moving in a weird way every time you move, but over time, your disc has worn down asymmetrically. And so it's collapsing on one side, but not the other. So that's a gravity problem. So you can't just go and decompress the disc and take out the piece of disc that's herniating out. It's going to still go down. And so propping that up and creating a structural solution in a fusion would be necessary. And then there's even more intense things like scoliosis and things like that that need to be addressed in a more structural fashion. And unfortunately, we don't have ways to add motion to the spine. Most of our, well, not a lot of ways, but most of our clinical toolboxes involved in that is eliminating the motion.
Yeah, that's really interesting. Let's talk about motion in the lumbar spine. So again, people often have questions about disc replacement surgery in the lumbar spine. Can we talk a little bit about when that is or is not appropriate for patients?
Sure. Lumbar disc replacement is one alternative to fusion. Surgery is done very similarly to a fusion that goes from the front of the spine, except instead of a cage with screws that eliminates motion, a device is placed that retains motion. And so the theoretical advantage of the disc replacement is that it can potentially reduce what we call adjacent segment degeneration. That condition occurs and is known to occur next to a fusion because when we fuse a segment, we do alter the biomechanics to some degree, and over time could accelerate the level of arthritis either above or below that said fusion. Even though there are theoretical benefits of a lumbar disc replacement for adjacent segment degeneration, this has not been borne out in the literature with long-term studies. Now, these long-term studies go out 10 or 15 years, so there's a chance that past that there could be a difference. But by and large, it is a theoretical benefit, in my opinion, not necessarily a proven.
And it's so fascinating that we're here at the Lumbar Spine Research Society because, again, this is a gathering of doctors and scientists who are looking at these different kinds of treatment approaches and what the evidence supports and what the outcomes are demonstrating. So I think we're at the perfect place to be having this conversation. Dr. Sedney, for lumbar spine surgical options, we've talked about decompression, and we've talked about fusion surgeries. We've talked about disc replacement surgery. What are some other treatments that are out there, or does that sort of cover it?
I think that is the vast majority of, sort of widely accepted, commonly accepted treatments. But one thing I would add is that, people often are very interested in quote unquote minimally invasive surgery. And so some of the most minimally invasive things you can do are injections. And so there's a huge place for that in back pain care. And so I think that it's would be remiss to not mention that.
Yeah. Well, while we're talking about injections, we've covered the main surgical techniques. Let's talk about some of the non-surgical techniques that you offer patients. And let's also talk about reasons why you would have a non-surgical approach. So Dr. Hsu, let's start with why a non-surgical approach?
Well, yeah, I think there are two really good reasons for that. One is that most people can get better without surgery. We know regardless of your spinal condition, whether it's a disc herniation or spondylolisthesis, or just an generalized arthritis-related condition, with all comers that come to see us, most people don't need surgery. So we focus on the most effective option initially. The other reason is that surgery has risks, and surgery has well-known potential complications, depending on the type of surgery and the length of surgery and what have you. And so when we weigh that risk-benefit ratio for some individuals, if their medical status doesn't make sense, then we wouldn't offer that person surgery, and we would rather focus on the non-operative options, which are much safer and still have a good opportunity to relieve pain.
And Dr. Sedney, if you'd like to comment on that'd be great. And then let's talk about what some of these non-surgical treatments are.
Yeah, so I think that the most important consideration beyond what Dr. Hsu also already said is that, you want to have a reasonable expectation that we're going to be able to fix the problem that the patient wants fixed with surgery. And so if it's hard for us to really localize where the pain is coming from, it's going to be hard to offer an effective surgical solution. And when you explain it like, oh, we can guess and do surgery here, and then that doesn't work, maybe we can do surgery here, people are kind of like, oh, now I get it. Now I understand why surgery isn't an easy option for this particular scenario. But again, if we can trace it right back to a very, limited, defined problem that we are reasonably sure we can fix, then surgery becomes a very good option.
And so some of the injections would include steroid injections. We hear some people talking about stem cells and regenerative medicine. Can you comment? I know that's a whole there are whole tracks being studied there. But could we say a few things that patients need to know about some of these kinds of treatments and what kind of outcomes they could expect?
Yeah, I'm happy to answer that question. You are right, Rita, that there have been many proposed biologics and biological materials that have been linked to injections within the spine. I would say that the evidence-based literature suggests that steroid injections have the most the highest efficacy and lowest cost.
What does efficacy?
Oh, the highest ability to work. The success rate. Yeah, exactly. They work well, and there are other potential components that don't necessarily work, even though you may not believe that. Listening to some of the marketing sort of approaches for that, but yes, in general, we use steroid injections pretty routinely within spine care because it's safe. It can be easily administered with an X-ray. We can usually schedule people pretty quickly. It doesn't take a whole anesthetic suite like we do with surgery and such. Yeah. And patients are also a candidate for multiple injections if the response makes sense for them to undergo this treatment modality.
Dr. Sedney, you were talking about validating pain, and sometimes it's hard to identify where the pain is coming from. What is the role of non-operative care in patients that don't have easily identifiable, X-ray or imaging pathology?
Yeah, so I think that injections actually play a really important role in that. They can help us identify where the pain is coming from, either through a temporary response or sort of a sequential ordering of the injections to see which one really helps the pain. And that can also help the patient both get symptom relief and also get closure, like, oh, this is where it's coming from. This is why I'm having this. So they can be very helpful for multiple reasons.
So last question for today is, we live in a world where patients are expected to play a role in the shared decision-making of their care. And I think one of the first things that people do when they're looking for medical information is they go to the internet and they go to Google. At the National Spine Health Foundation, we are working very hard in partnership with groups like the Lumbar Spine Research Society and others to bring responsible, credible, honest, vetted, unbiased information for patients to learn from and to understand. Can you help us understand how patients can better educate themselves on what is going on with their bodies so that they can make better choices with their doctors?
Yeah, Rita, that's a great question, and it comes down to the source of the information. Whether you Google or search on the internet for any topic, for that matter, a number of sources can come up that will cloud the answer to the question that you're seeking or the solution that you're seeking. And spine problems, that we're no different. So yes, I feel like half of my clinic is spent trying to right the wrongs of many things that come up as a result of an internet search that goes awry or goes wrong. And knowing where you're getting the information regarding treatment, regarding symptoms, and regarding potential surgical options really comes down to knowing the source. And in my opinion, the NSHF should be your first stop.
Great. Thank you. Dr. Sedney, comments on you treat a lot of rural patients that have difficulty with access to care. how can they best get informed?
When we talk to our patients about health access, the actually telemedicine and the internet are very accessible to most patients. Sometimes that doesn't look like it does in urban settings. Like I'll have a patient do a telemedicine visit on the side of the highway because they don't have internet or telephone access at their house. But by and large, these types of developments really are improving access and are very usable for our patients.
And going to a reliable source and a credible source for that information can be very helpful. So we appreciate you participating with us in helping to create really good information for patients and a starting point for educating herself and getting hope to know that there are treatments out there that can get you out of pain, that can help you get back to your life. So I want to thank Dr. Hsu and I want to thank Dr. Sedney. They are healthcare heroes who put the best of science into practice every day for their patients, and we thank them for everything they do for their patients and for the National Spine Health Foundation.